won't be here, we can pass that along.
Absolutely.
Okay, well, I think we'll get going then. Welcome everyone. If you don't know, I'm Marcia Hay McCutcheon, and I'm the director of the Rural Health and Health Disparities theme with the Alabama Life Research Institute. And both Dr. Charlene Newman, who's the executive director of the Alabama Life Research Institute, and I are glad you could make it to this presentation by Dr. Pérez-Stable. And as you know, Dr. Pérez-Stable is the director of the National Institute on Minority Health and Health Disparities. And before moving to the NIH in 2015, he practiced general internal medicine for 37 years at the University of California in San Francisco. And during his time there, he was also professor of medicine and chief of the Division of General Internal Medicine for 17 years. His research interests include improving the health of racial and ethnic minorities and underserved populations, advancing patient-centered care, improving cross-cultural communication skills among clinicians, and promoting diversity in the biomedical research workforce. For more than 30 years, he led research on Latino smoking cessation and tobacco control policy in the United States and Latin America. And this project also addressed clinical and prevention issues in cancer screening and included the mentoring of over 70 minority investigators. He has published over 300 peer review articles and was elected to the National Academy of Medicine in 2001. So we look forward to your presentation, Dr. Pérez-Stable. Welcome.
Well, thank you so much for the invitation today. I know that we had to reschedule the prior meeting, and I think there is going to be some small group sessions after the lecture, so that's great. Fridays are always a good day, I think, and so this is a great way to proceed. I'm going to go ahead and share my screen. I've targeted about 45 minutes for my talk, so we can have some conversation. And then, and let's see, here we go, slideshow. So everybody's able to see this okay? I trust, and hearing otherwise, I will go on. As you heard, my background is as a general internist, so I've always had a broad view of both health and people, patients. And I've brought that to my role at NIMHD. This is my 6th year as director of the Institute, and believe me, the last few years have been remarkable. I think the pace of work in 2020 was not sustainable, but somehow we have to find the energy to keep going and find a new way to operate as we get through this period of pandemic. I wanted to start just with acknowledgement that this is a critical weekend. It's a Martin Luther King holiday on Monday, although tomorrow is his actual birthday. And if you have not been to the District of Columbia to see the wonderful monument in his honor, I encourage all of you to come and visit. He is clearly one of America's heroes of the second half of the 20th century. NIMHD's defines populations with health disparities as follows. The first 3 bullets that you see on the slide, whereas in our original legislation from the center in the year 2000, all racial and ethnic minority populations as defined by the census, so that's possible that could change in the future. Poor people of any color are included. So whites who are poor, and then also underserved rural residents. Now, I qualified the rural residents to underserved just to make sure we were not addressing issues of, as I would say, the wealthy ranchers of the Central Valley of California. And then in 2016, we declared sexual and gender minorities as a population with health disparities. This was a process that took several years, led by Larry Tabak and others at NIH. I came in the last year. It was cleared through the Department of Health and Human Services. And I think the convincing issue is the next bullet, where we endorse the idea that social disadvantage exists for all these populations as a result of being subject to discrimination or racism, and also being underserved in healthcare. So a health outcome that is worse in one of these population groups compared to some reference group is what we define as a health disparity at NIH. Now, race, ethnicity, and socioeconomic status as social determinants, demographic social determinants, are fundamental in influencing health. And this has been another message I have used consistently at NIH, and I think to some clinician investigators, this was new. If you look at the data, population-wise, race, ethnicity, and socioeconomic status predicts so many things that are not fully explained, like mortality, total mortality, and life expectancy, that we need to measure them in a standardized way and include them in all studies with human beings, even if they don't turn out to be significant predictors or important. African Americans, for example, have many more strokes when compared, twice as many strokes actually, compared to whites for the same level of systolic blood pressure. And this comes from the REGARD study, which is in part run out of the University of Alabama, Birmingham. Most chronic diseases are also more common in people who are poor, and this is not because of poor behavior only. There are many other factors that contribute to this. And then even within the diagnosis of diabetes, type 2 diabetes, from the Kaiser Diabetes Registry in a 10-year prospective follow-up, all minority populations in that registry had about 20 to 30% less heart disease. That means heart attacks and heart failure, but twice as much end-stage renal disease. So same disease, same system, similar healthcare, if you wish, and outcomes that really matter are dramatically different by this crude, self-identified social factor of race, ethnicity. So I would say that until proven otherwise, these are critical factors that need to be measured and considered in all this kind of research. So what can science do to reduce inequities? I already said this, and I'll repeat it, I'm sure. Standardized measurement of these factors that affect health. The basic scientists have certainly gotten on board with doing it in their field, and certainly laboratory measures tend to be standardized. We need to do exactly the same thing in survey data, all social demographic data, and I'll come back to this. We need to facilitate discovery science with big data. So data science is really critical. It has just taken off in the last decade. And I would encourage all groups to really have expertise in artificial intelligence, machine learning, data science. And discovery science can be done with large, very large data sets from electronic health records, from the repositories of multiple studies. We also need to be an engine for promoting diversity of the scientific and clinical workforce. I will just mention at this point, 14% of current medical school graduates and newly minted PhDs are from underrepresented groups. And the workforce doesn't reflect the fact that 30% of the US population are from these underrepresented groups. So we have a crisis in that regards, and we have to do everything that's within legal boundaries to work on diversifying the workforce. We have to cultivate community engagement. This goes for the full spectrum of research. I think the COVID-19 vaccine is a great example. We had a terrific product. We thought, well, we'll build it and they'll come. Messenger RNA vaccines are a remarkable achievement. They're clearly bumps in the road with the pandemic, but what happened is people were skeptical, hesitant, and we really needed to have a very robust platform of community engagement in order to do this. And this has to be done building trust and for sustainable relationships. It's not one study at a time. It's really an ongoing thing, and we'll come back to this. And then we need to implement what we know can work. It is embarrassing that in some areas like control of blood pressure or control of diabetes, the groups that have the worst outcomes, African Americans and Latinos, for example, have the lowest rate of control. And this is something that we as clinicians know what to do and how to do it, and yet we don't do it in the groups that are most likely to suffer. These are data from the United States from 2016. This relationship, I have not seen an updated analysis, but if you see that if you're at the poverty level for a household of four, about $25,000 income annually per year, you're 3 times more likely to die from any cause compared to an income of $115,000, which we know is well off, but certainly not wealthy. And you see this as a robust gradient. And knowing this, I would say most clinicians, even the great clinicians, often don't know the socioeconomic status of their patient, or have a sense, but don't really have this data. We don't routinely collect this like we do body mass index or tobacco use or measure blood pressure. So I think that the data are there to say that this is a really critical part to incorporate. I'm going to show you 3 examples of what I would say are stratified analysis of population data, which is really the direction we need to go. This is cigarette smoking data in the US. I've done a lot of work in tobacco research, tobacco use research. You can see some variation by race, ethnicity of interest, not consistently. Minorities are worse. You can see Latinos and Asians actually have the lowest rates, and American Indians the highest. But look at the gradient by education. This is total population, of course. And if you're less than high school, you're the highest chance of smoking, or 9th to 11th grade, I should say, because people with less than 9th grade have lower rates because they tend to be immigrants. High school graduate goes down, undergraduate degree goes down, and if you have a PhD degree, it's even lower. So clearly education is good for your health, and this is a message also. This is a data from the CDC published several years ago, looking at the prevalence of obesity among youth by the educational level of the head of household, as defined in the survey. Now, whatever the definition that was from their methods. And I'm just showing you the comparison of the respondents who had less than high school for the head of household compared to those with a college degree. So not the intermittent results. You can see that the improvement from having more education for the head of household is fairly consistent and dramatic. It's actually most dramatic for white females, and least effective for Black females, although in general, the gradient is always in the right direction. But also notice that the minority groups, Blacks and Latinos especially, and start off at higher rates of obesity. So this is the kind of approach we need to do more of. Now, of course, it needs sample size. If you use population, entire country or entire state, you have a lot bigger sample, and not to exclude doing more vertical studies with smaller samples, but it's important to not consider race, ethnicity as associated with an outcome without considering socioeconomic status. I think this is a fundamental message. Now, here's another third example of national data with stratification, in this case by rurality or residential urbanization. And the more rural areas is on the right, the more urban area, the most urban areas on the left. First of all, notice that African Americans or Blacks have the lowest rate of suicide in the country generally. And this hasn't really changed as we've seen the epidemic or the increase in rates of suicide in other populations, particularly whites and American Indians. Everyone else increases by rurality. So, but Blacks don't. And African Americans who live in rural areas are primarily living in the Deep South. So Alabama certainly is one of those states. And so this is an observation that has not had any real explanation as to the cause. Of course, race, ethnicity, and socioeconomic status are not the only social determinants of health. I like to categorize those as demographic social determinants of health, including age and gender. There are other individual measures of social determinants of health. Some may be cultural identity, religious or religiosity or spirituality. In clinical care and in communication and public health, clearly language proficiency and literacy are important. There's a robust literature on health literacy. Numeracy has been less well studied, and this is actually sort of risk perception is really important. Most people don't think quantitatively. And you talk about, oh, you have a 5% risk. People say, oh, that means 95% chance of not having a problem. So they think that that's pretty good. And so we have to be careful on how we use this in terms of numeracy. But the area that has gotten the most attention in the last few years has been the structural social determinants of health. All these factors listed here. I made this slide before the pandemic, but you can see the importance of having access to broadband internet. And now that we have been in a virtual work environment for going on 2 years, But all these other factors are critical. NIMHD undertook a process about not quite 4 years ago that's called Phoenix Toolkit on the social determinants of health to try to get NIH to vet standardized measures that we would all endorse, so to speak. This required both NIMHD and an NIH-wide group of experts to consider this. And then we went through a grant process to get an external committee of scientific experts to do that. We finished one phase, and that was launched in May of 2020. We are now in the launching the second phase, mostly now focused on the social determinant, on the structural social determinants of health. The link is on the slide. It's Phoenix, and we have a website that you can see with just 3 little colored houses. The other thing that we were able to do in the beginning of my time at NIMHC is develop this research framework. Staff did this to really capture the complexity of the research that we're involved with. And it tries to incorporate sort of the newer areas of science that have influenced disparities in minority health. Biological, for example, all the data we have on genetics and epigenetics, microbiome, telomeres, and the brain initiative really need to be considered in these factors. And in the physical built environment, where again, for the last 20 plus years, this area of science has really exploded. The notion that your zip code is more important for your health than your genetic code is true. And why is that? And then we'll come back to this in terms of structural racism. But all these other factors, there's no causal arrow here, but if I was to draw one, it would be from right to left. And I think we've had this up now for several years, and probably will look and consider whether we need to tweak or think more about how it is designed. I was asked to say a few words about what our funding priorities are, and we're interested in all things human that relate to racial and ethnic minorities, or the populations that I described. We're more focused on common problems, more public health issues, as opposed to rare diseases. I can say that categorically. But these are funding opportunity announcements, just a sample that we have active now. Now, these are not set-asides for the most part. These are really a sort of announcement saying we're interested in applications like this, and that usually gets investigators thinking about it. I won't go through the whole list. You can see many of these are done in collaboration with other institutes. Sleep disparities is with NHLBI, for example. Patient-clinician communication is relatively new. This was just published in 2021. We just published this care. It should be patients with multiple chronic diseases. This is actually, it's a little different. We're going to do larger grants for this. Also is relatively new and role of work in health, and we will be funding of grants, but I'll come back to that. NIH has funded through other institutes. This is an example of some of these. I'm getting a signal that my internet connection is unstable, but hopefully you'll let me know if you can't hear me. We have environmental disparities centers with NIEHS that we lead. We co-fund the Jackson Heart Study, which is based just next door to you in Mississippi, and the Hispanic Community Health Study of Latinos that are both NHLBI cohorts. The ABCD study is this massive study of 12,000 adolescents led by NIDA and NIAAA that is ongoing, a 10-year study. ECHO, the Alzheimer's disease and related dementias, the NIA has allowed supplements to non-Alzheimer's grants from other institutes, and we've been able to benefit from this thanks to the NIA's program on this. Apollo Network is looking at APOL1 in a network that NIDDK funded, but we are supporting as well. And then other things that are NIH-wide, like All of Us, of course, Opioid Use Disorder or HEAL initiative, the HBCD cohort. And most recently, I'll just mention the multiple chronic disease research centers. We did fund the University of Alabama, so you have one next door in Birmingham. These are large grants to study multiple chronic disease patients to do interventions. and it was a congressional set aside. They requested that we lead this NIMHD in collaboration with other institutes, and we didn't ask for the money, so it was great to get it. Just to give you a sense of what our budget is, our current budget in 2021 was $394 million. We're in a continuing resolution until they have appropriations, so that's what our budget is this year. We fund a large program for minority institutions, the research centers for minority institutions. There are 21 funded. Again, there is one in Tuskegee. So again, in your state. The RPG pool makes up less than what the usual NIH-IC Institute does. We're about not quite half. Most of these are R1s. We have a very small intramural program, and we do have another center program that we do. And under contracts includes our support of the cohort studies I mentioned. You can take a look at our K award. When I arrived at NIMHD, we only funded K99s. We opened that up. It took a little while to get that going, and we have now reached this level here. I'm hopeful that this will continue to grow. I know fiscal 21 was higher. We don't have the final numbers. I didn't have a slide on the final numbers that I'll be presenting those at our council on February 4th, I think, if you're interested, and that's an open meeting. But this is really a critical part of our component, K01, K08, and K23. And we continue the K99 program as well. Just a couple of words on COVID, of course. This is from 2020, and I will always live in my mind the day that Dr. Fauci was on one of those evening news conferences and started talking about health disparities. He was there with President Trump and the rest of the team that was managing the COVID crisis at the time, and emphasized especially the impact on African-American communities, although subsequently it became clear that it was more than African Americans. We collaborated with an intramural group at NCI that does population science research. Meredith Shields is the first author of this paper. 477,000 excess deaths in the year 2020, the calendar year 2020. I think calendar year 2021 will be equally bad or worse. About 3/4 were estimated to be caused by COVID. The rest are deaths related probably to unattended chronic diseases or misdiagnoses or lack of access. We don't know. These are just preliminary causes from the CDC, so it often takes a while to really get more granular from the clinical data. African Americans and Blacks, American Indians, Alaska Natives, and Latino Hispanics had 2 to 4 times the death rate of whites, and you can see that men more than women. Well, that's usual. Men usually have higher mortality rates than women, but this is just staggering. And this level of disparity really had not been seen, at least in my time, in the 40 years I've been a physician. Over the course of the pandemic, now going into year 3, although I haven't reviewed the most recent data, and Omicron is going to certainly give us lots of new data, maybe not as bad as because of the vaccination rates. Case rates, hospitalizations, and deaths for Latinos, African Americans, and American Indians have been 2 to 3 times that for whites. Probably also for Native Hawaiians, Pacific Islanders, although they're much smaller populations, so harder to make definitive conclusions. Clearly not the case for Asian Americans globally. There's more exposure for these groups, and this is due to social conditions, jobs, and access to healthcare. Not because of pre-existing conditions. The pre-existing conditions probably contribute to some severity, and the extreme obesity or diabetes or heart disease or pulmonary disease, but it's not the main reason why we see higher infection rates. This estimation of losing 2 to 3 years of life expectancy, Latinos have had a life expectancy advantage that has been markedly reduced as of 2020. We'll see what happens over time. And for African Americans, all the gains that were made in the 21st century, which were substantial, may well have been lost as a result of the COVID pandemic. Initially, the vaccine hesitancy was highest among African Americans. That has changed. At least as of in the fall, the rate of vaccination for 1 dose was not different for Blacks, whites, and Latinos. Of course, we know one dose doesn't do as much. We need at least 2, probably 3 now, to prevent the most severe manifestations of the disease. Rural Americans and those with less education are least likely to receive vaccines. So I would say that the commentary we wrote with Monica Webb-Hooper, my deputy director, and Anna Annapolis, scientific director of the intramural program, unfortunately, much has not changed since we wrote that. Now, the NIH response, I'll just mention 2 of the programs we are co-leading. One is the RADx-UP. This is Radical Acceleration for Diagnostics, and it's for underserved populations. These were supplemental appropriations from Congress in April of 2020. Dr. Collins, after reflecting on where the crisis was most important, allocated a significant proportion of these funds to addressing disparities. I was charged with co-leading this along with Richard Hoda as a director of National Institute on Aging, and at that time, Tara Schwetz, who was in the office of the director. She's moved on to more important jobs. She's now the acting principal deputy of the agency. We have funded almost 100 grants over the course of these first year and a half, starting in late September of 2020. We're launching a phase 3. There is a notice out for new applications. There'll be UO1s. We're not going to rush them because clearly this is going to be with us for a while. And we're going to, the notice will say we're focusing on rapid testing. So if any of you are interested in that area, I encourage you now to start thinking about it. The applicants will be due about 3 months after the funding announcement is launched. But you can see that we're all the way from Puerto Rico to Hawaii, stretching across, and about 10 of these projects are actually primarily focused on American Indian, Alaska Native populations. We funded a large coordinating center at the University of North Carolina, Duke, and the data, they're helping us coordinate. This is a consortium. We're trying to get scientists to actually collect data using common data elements, to share the data and deposit their data. And so we have all these projects. Large number of tests have been distributed and done. And at this point, over 850,000 participants have been enrolled. And this is probably the largest single project NMHC has ever led. This is a $20 million a year, this coordinating center. And I think it really has put us in the forefront of NIH research. The second program I'll share with you is this Community Engagement Alliance Against COVID-19 Disparities. This actually arose more spontaneously, empirically, and through the challenges of the recruitment for the Moderna clinical trial. Dr. Gary Gibbons, the director of NHLBI, and I were involved with Francis Collins, Tony Fauci, the Operational Warp Speed Group, and Moderna's leadership in the summer of 2020 to say, how can you do better? Their initial recruitment was 90% white. And Francis did not think that was acceptable. So we advised them, we worked with them, and they ended up at 37% minorities in their trial, which we think was, pretty good. I would say a B, right? If you graded it, but clearly better than where they were headed. And out of our efforts to say, well, Gary Gibbons said, I'll put in $2 million. I said, I put in $2 million. Dr. Fauci put in more money, and then Dr. Collins went out and got money from the department. We stood up this SEAL initiative. We're in 21 states. Again, we're in Alabama, and these are meant to be partnerships that are statewide or regional. In the District of Columbia, Maryland, Virginia area actually is a regional one funded out of Johns Hopkins, but partnering with Howard and Morgan State and University of Maryland. We don't know where this will lead us. It stood up with money that we found. We're waiting for appropriations this year. But I think the principle here is that this is a community engaged platform to really, in full partnership with communities and community leadership and organizations, engage the community to advance the issues on disparities related to COVID. Now, this SEAL will not be able to do everything, but I think the principle of it is that this can be a model for other issues. And of course, the platform that we've created with SEAL needs to be continued in the foreseeable future. We've had a huge emphasis on information and communication. I would say that the misinformation, whether intentionally to divide or not, is something that none of us predicted would happen, and that NIH feels that we need to be more prepared to address this, and in fact be proactive about how we communicate about science. So trusting science is not something that people will automatically do. And in this day of rapid cycle of information and news, we really need to be on top of this. Let me now turn to the topic of racism, which I think was a specific interest of this group. These are data from the Kaiser Family Foundation dating back to 2015, asking about in the past 30 days were you treated unfairly because of race or ethnic background in different types of settings. And astoundingly, 53% of African American respondents, this is a population-based survey that Kaiser Family Foundation does, said yes to this. And 36% of Latinos compared to 15% of whites. So clearly we have a problem as a country. And I think everyone now, after the murder of George Floyd and all the developments of 2020, most people are aware that this is not, talking about racism is, frankly, not polite conversation. So I would say a lot of professionals, a lot of colleagues would not bring this up as a topic. But clearly NIH has taken a different approach on this. And I'm encouraged by it, but this is a long haul, not a short one. So let's think about research as a research construct, and what are the categories that we would or think about. The most commonly studied area is interpersonal. So you have a survey, and there are great measures. They're on the PHENIC website. David Williams, Nancy Krieger, others have worked on this over the years. Really reliably, psychometrically reliable measures. Associations established mostly with behavioral outcomes and mental health outcomes, some with cardiovascular outcomes, less robust with others, and I'll go over those in a second. Internalized racism is where someone says, no, never, don't have racism, no, I don't know what that is, no one discriminates me, but that individual has internalized these exposures and sublimate them either cognitively or biologically. And some have tried to study this, including our group, using measures such as allostatic load, or others have used telomere length. Less studied, the issue of perceived societal discrimination. There's a very good study out of Los Angeles on this from adolescents. Not what you've experienced, but what do you perceive out there? And again, it was a one-year follow-up did influence depressive symptoms, and substance use behavior among these 11th and 12th graders in Los Angeles, a very diverse group. And then the secondhand effects of racism, this concept would come from smoking work, for example, but what happens to individuals who are cohabiting or children of someone who's been a victim of racism? What does it do to them? And I think this is very, very new territory. Very little research has been done in this area as far as I'm concerned. Most important thing about exposure to racism or discrimination is to conceptualize it as a form of cumulative chronic stress with long-term effects. So the model that most scientists have accepted is the adverse childhood event model. So how important those first 3-5 years of life are, and how that influences what goes on when you're 40 or 50 is what we ought to consider how racism is. So short-term studies can only inform us so much. And this is not, events. Major events do happen, but it's really a cumulative chronic exposure. I mentioned the measures. I think the effects on physical and mental health status of African Americans, particularly men, was first demonstrated by James Jackson and David Williams and others out of the University of Michigan. The studies on racism on physiological measures have been studied in laboratories where you expose an individual to blatant racist activities like the apartheid in South Africa, and you see the systolic blood pressure go up or level of inflammatory markers go up. This is the kind of research that has led this to this kind of work. But the data on health behaviors, I think, although not always there, but it's fairly consistent direction that more smoking, more problem drinking, more substance use. And we even did a study in South America with youth and showed that the racial insults was associated not with smoking, but with drinking and other substance use. Other data, other disease outcomes is less robust, and I think this is an area that needs to be studied a lot more depth. Structural racism is relatively new to this discussion because many people weren't sure, well, how do you study this? And what is it? And does it even exist? This is the discussion, 10 years ago. I think now many people have accepted this is historical, cultural, institutional policies that codified practices that have perpetuated inequity by promoting an ideology of inferiority. We cannot ignore or change how we were born as a country, how the Americas developed. I mean, I'm from Cuba originally. The Americas has this history. The indigenous people were there was genocidal activity against indigenous people in this country or in the Americas, and there were 6 million Africans forcibly brought to the Americas to be slaves. And out of it came this whole continent or two continents, and I think that's recognition doesn't mean the individual is responsible. I mean, we just have to acknowledge it. That's the starting point, and there are many people who still obviously are resisting doing this. There is an organized system that categorizes, ranks, devalues, disempowers, and differentially allocates resources. And the best example of this, I think, is the residential segregation policy that was really implemented in the 1930s and impacted the development or the access to wealth for differentially for whites and blacks and subsequently Latinos. And initially, the World War II, when all the soldiers were returning, the American economy sort of took off. The ability to get a loan to purchase a home was differential, and it was banks who redlined communities. Almost all cities in the United States are segregated. Not all, but some more in the east than in the far west. But these exist, and there was direction that you don't provide loans in this area. And so how do American families build equity or wealth is through purchasing homes. So, and this, of course, also impacted economic resources because businesses weren't available in that area. Educational quality suffered, so public schools, and then access to other services, whether it be transportation or healthy food. Keep in mind also that public education in the United States really didn't become a public good until the 1930s. So a lot of this really are interconnected. Now, we know now that redlining is illegal and that obviously this shouldn't be happening anymore, but we are, I think, suffering those consequences. How do we measure structural racism? I don't have a quick answer for you. Most people have used data from population metrics from the American Community Survey, which is the way the census updates its data with large survey between the decennial census, derived by census tract. You can get to census tract with the exact address. Zip code gives you gives you moderate information. It's better than nothing, but I think it's again a critical data point that we probably should be doing routinely in all of our patients. So operationalizing structural racism as a research construct for health studies was in many ways a new thing for me as director of NMHD. So in 2017, we sponsored a scientific workshop on this with the Office of Minority Health at the department. And we just published it. We did publish a report on that, but nothing else disseminated from it. And of course, in 2020, all this kind of became relevant. And after the new administration came, we did publish a request for applications, although this is of course closed. All the grants were submitted. They've been reviewed, and I can say that we have many good applications that will be funded. Of course, institutes are a little cautious until we have an appropriated budget, but we will be making some decisions for our February council. But it was not just an MHD. There were all institutes signed up and the grants were assigned across. More importantly, perhaps, the Common Fund program jumped in, funded 11 grants with $30 million Some went to minority serving institutions or less resource institutions. There's $5 million more available this fiscal year from the Common Fund for MSIs only. And we're working on a large program for 10 years that will be launched, and we hope will be launched in fiscal year 23. It will be presented at the Council of Councils, sorry for the typo, on January 27th, which is a public meeting. So if you want to listen to it, it will be at 1:45 Eastern time. I'm not presenting. Shannon Zenk and Josh Gordon will be presenting. I'm one of the co-chairs of that. A couple of examples of how structural racism may be playing itself out. These are data from Elizabeth Howell's research when she was in New York City. And really remarkable. When I showed this to congressional briefing, they were just amazed. So if you go to a low Black serving hospital in New York City, predominantly not non-Blacks are in that hospital, you can see the difference in severe maternal morbidity, now not mortality, because this is the maternal mortality is about 1,000 per year in the US. About 100,000 women have severe morbidity. So this is an easier, and it's in the causal pathway. So this is a good way to look at this. If you go to medium Black serving, you can see the gradient going up. You go to high Black serving hospital, white women actually have as high a rate of severe morbidity as Black women, and in fact higher than Black women in the low Black serving hospital. So, and this is already adjusted for individual demographic and socioeconomic status and preconception health status. So this is something structural. This is the hospital or the people in the hospital, and again should be modifiable. And this is complicated, but just a big SEER study. This is a cancer epidemiology registry that the NCI funds, linked to outcomes. Looking at breast cancer, if you present with breast cancer in stage 3, you essentially have uncurable disease. You can be treated and do fine for years and years, but it's not curable. If you have either Medicaid or no insurance, you're more likely to present with stage 3. And also if you are Black or Latino or American Indian, you're more likely to present with stage 3. The two contributed, again, adjusted for insurance, African American and Latino women still had a higher risk of presenting with stage 3. Lack of insurance is a structural factor. It's a structural racism, really, because minorities, particularly Latinos and African Americans, are much more likely to be uninsured compared to their white counterparts. So why health equity structural interventions are important? I mean, acknowledging that we cannot solve this with individual-based interventions. This has to be system, it has to be multi-levels. You can't ignore the individuals either. And these upstream structural drivers are really important. Just the notion that, oh, if you get more education, people's health will improve. If women go to school, they're not going to have 7 or 8 babies. They'll have a family, but it will be a different format. This has been shown globally in every society that has begun to educate women. And there's been very limited NIH research in this area. It has to be community driven, and this is what we're expecting to do with this Common Fund program. Just a sort of a panorama of types of interventions that we're referring to. One could be insurance. I think there is a study called Movement to Opportunity, which was to give low-income women, single parent homes, mostly women, who were in 6 different cities, vouchers to move to a neighborhood that was higher income. And it showed that not only did it improve their health, did improve their overall status, but their health status improved. And those with BMI went down, and hemoglobin A1C went down. One of the papers from that study was published in the New England Journal. There are consequences. The adolescent boys, for example, who were in that study did not do well moving to a higher income neighborhood, but the preteens, the pre-adolescents did much better in the long-term follow-up. This was a study funded in the 1990s, done out of not out of NIH, although NIH jumped on it to co-fund it. It wasn't intended as a health study, and now I think we're going to try to get studies like this done. Ideas of how to mitigate racism. Obviously on an individual level, these are some general recommendations I would make. How critical early childhood education is. That's one of the most important things of the bill that is now stuck in Congress about really fortifying our investments in early childhood education. I really think that we've not paid enough attention to children in the United States. The racial socialization, or what people would call integration experiment, actually was working before we abandoned it in 1980. You can look at the trends of African American health improving steadily in the 60s and 70s, and then stagnating and getting worse throughout the 1980s before they started improving again in the mid 1990s and throughout, at least through up until or before the pandemic. So this is something again to reconsider. Social cohesion, interacting, things of the religious communities, people who meditate, mindfulness, all these are interventions or components that will make things better. In the healthcare setting, I think access, cultural competence, precision care for individuals in patient-centered medical home are important. But ultimately, we need to recognize that racism is not just about individual behavior. It's really about power and structure of institutions and policies. And we need to acknowledge that and find ways to mitigate that. I want to emphasize the importance of patient-clinician communication. You already saw we have a funding opportunity announcement on this. I think that this can be critical in long-term care of people with chronic disease. 20-30% of the population goes to see a clinician frequently. And again, the lack of diversity is really important here. I already mentioned this, so I'm going to go quickly through the last few slides so we have time for some questions. I want to mention the NMHD Health Disparities Research Institute. We launched it in 2016. It's a 1 week. We've done 2 years now virtually. We do a mock grant review. We have selected lectures. Time for the scholars who attend to interact with staff. I think that's also extremely valuable. And they do consultations on their ideas, their research ideas. This is part of the requirement. Our goal is to bring in people who, scholars who are going to apply for an NIH grant, K or an R grant, either one. So we've had 330 participants in 6 years. About 60% are from underrepresented minority groups, and about 20% are physicians. Of course, none of these are criteria for selection. In person, we limited it to about 50, and in the virtual environment, we've had about 60. Just a wonderful photo. I love these screenshots of all these wonderful young scientists who attended this, our 2021 Disparities HDRI. We also have a loan repayment program that all of NIH has, but I think there is now good evidence. We're working on getting this fully analyzed and written up, but at least preliminarily show that the NMHD program, that they're more likely to get an R01 and more likely to stay in research. That's been consistently shown. Finishing up, just a few general comments. Health equity and health care to reduce disparities. We need to expand access. We need to do the things that we know how to do well. We need to have good coordination of care, patient-centered care, and leverage health IT and electronic health record to address equity. This has not been a priority in the past, and I think now is a good time to emphasize this. And I know CMS has been thinking about this, about developing an equity quality measure. So not hold a system accountable just for doing more mammography or getting shorter or having fewer people readmitted to the hospital, but also equitable care, defined by whatever factor we're using, whether socioeconomic status, race, ethnicity, the most underprivileged group is being equitably managed. I already emphasized the importance of community engagement, so I won't dwell on this. I think the time is now to build this, and I would not be able to do any of this without the full partnership of Gary Gibbons and NHLBI and the support of the NIH leadership in this. But I do think this is an important platform for future research in many areas. Leave you with just these 4 comments. interventions frequently, we don't have a magic bullet drug. So we look at multi-level interventions. If you're working in a healthcare system, you work with the system, you work with the clinicians or providers, and you work with the patients, and similar patterns in communities. We have to identify mechanisms. I don't think that we have to abandon discovery science in this field at all, whether they be biological, behavioral, or social pathways, and also the issues around system. I already emphasized communication, and then implementing structural change is sort of like put in the stairs so people don't take the elevator to the second floor, or make chilled water freely available to middle school students so they don't drink sugar sweetened beverages. So thank you for your attention. I hope we have time for a few questions at the end of the show, and stop sharing, and then we'll be able to have time for a few minutes for questions.
Well, thank you very much, Dr. Pérez-Stable, for this really engaging and interesting talk. I just want to let everyone know, too, that Dr. Pérez-Stable has shared his slides, and so we'll distribute those. But at this point, are there any questions? And I think we have a small enough group that you could probably ask them verbally.
Yes, unmute and ask.
Oh, hello. I'm Charlene Newman. I don't know if you can see me here. So I'm the director of the Life Research Institute. So welcome. And thank you very much for participating and coming to talk to us, or virtually coming to talk to us. So I have a sort of maybe a larger question. So we, of course, would be thrilled to have a study funded like the Jackson Heart study. And so, and thinking about that and doing something in Alabama. So I don't know how much you know about Alabama, but Tuscaloosa is adjacent to the Alabama Black Belt. We do a lot of work in the Black Belt. A lot of us are doing community engaged work in that space and have very good relationships with the community. And as you also know, we have lots of health disparities in the state. And so we can probably just sort of throw a dart at a board and pick something, and we have that issue in the state of Alabama. Mm-hmm. So just in thinking about that, like what kinds of things would we need to do in Tuscaloosa to maybe prepare for something like a Jackson Heart?
Well, yeah, it is a big question. If you send me an email, Charlene, I'll be happy to connect you to some of the program staff. Maybe Nate Stinson can be helpful in providing some guide. NIMHD does have a listserv, and you can sign up for it and get all our announcements and all updates. It doesn't happen overnight. I think you build a team and you look for opportunities. And I think I like to say, I had a mentor early on in my career that said, small is beautiful. So we can start small and build. You do have the advantage or disadvantage, depending on how you look at it, but I think it can be leveraged as a big advantage of having experienced and successful programs close. So one possibility is to find ways to connect and collaborate. I mentioned the University of Alabama, Birmingham. They've done a lot in this work, and they've Mona Fouad and Selwyn. I forget his last name. So he's the dean. Vickers, thank you, of the University of Alabama, Birmingham. The Jackson Heart Study, of course, is based in Jackson, Mississippi, and I visited Birmingham in my first year of director, so I am familiar with your state, and I love geography and I love thinking about population. So I've become very familiar with the whole history in the South. And obviously, in my role, having spent all my years in California, I knew about it, but it was two steps removed from me. And I was struck my visit to Jackson, Mississippi, not in Birmingham. I think Birmingham is a different ambience. And in talking to people there, and in looking at how Mississippi is, to this day, set up and divided. Even within the Jackson Heart Study, there's Jackson State, where we have a research center for minority institutions, and then there's the University of Mississippi Medical Center, and the dynamics there are interesting as well. But it's a long haul effort. There are going to be more opportunities, and I would encourage, along the lines of building and having strong community engaged partners, having the scientific expertise in these areas of population science, social and behavioral issues, but not losing the biological component as well in this area. I think it does take a village in that context. And looking for ways to partner with existing programs. There will be opportunities. So I'll send me an email and I'll link you up to a couple of staff in our institute who can give you some advice on this.
Okay.
I had a comment, Pam Foster, Community Medicine, Population Health. I've been doing CPPR a long time. And one of the challenges is people really understanding it. Academics and community members. I wondered if there was ever thought of training centers to really get people the skills they need in order to do it. Some academicians have the skill sets, very few. And it's the same for on the community side.
No, that's a great point, Pamela. I appreciate that comment. I think that I call it community engaged research, so we don't get stuck in a sort of methodological lane. Has been around at NIH now for many years. In fact, my very first grant was a community, turned out to be a community intervention. Wasn't that way the way it was initially. It was on smoking, but the National Cancer Institute, the NHLBI now, and others have funded programs in this. It's sort of like, okay, we're not so sure, is that really science? And that's been the attitude. It has been modest or small investments in that. I think the pandemic has changed that, and I think people now understand the importance of this. Look for the Common Fund program to really create opportunities for this. One of the things we've discussed has been precisely what you highlighted. I think there are many scientists out there who know how to do this. I think we need to know how to work with each other, and that the community leaders and community staff, or need to either how to hire a scientist to work with the community organization, or they have to understand what's the academic people like, because I think that there is a gap there. And what you said is true. The academicians, researchers need to know what are the priorities for community organizations. The one risk that has come up is that people are talking about research tourists now. Now Disparities is being funded, so all of these people or high resource institutions are coming to the table and asking for funding. I don't think it's either or at all. I think that we can welcome others and we can also collaborate. So the Common Fund initiative will in part reflect on this. We don't, NMHD itself doesn't fund a lot of training programs. But I think the point about that we expect will be part of the Common Fund initiative will be specific training, as I described, so that how do you, what do you need to know as a community leader about research in order to really work well with researchers? And what do researchers need to know about community priorities so that they have, mutual respect and trust that builds over time? What I think matters the most is some common sense and sustainability. So when I first went to the Latino community in San Francisco, they were thrilled. I mean, they never had a university faculty come to visit with them, and that's another thing. You have to do FaceTime, and you have to go to the community. Of course, now we are all kind of doing Zoom, but you know what I mean. I think that the regular researchers just didn't see that as important, and it's so critical. And then sustainability. You can't just, you may not talk to each other for a year, but if they call you, you make sure you're there for them, and they'll be there for you when you call them. That's what I found. That it was, and I think that these are features that time and time again, I think there is a workforce that knows this in the scientific side, I don't think that the training has to be more of sort of a, how do we work together? That's my opinion, but there could be room for more. Yeah.
I put it in the chat, common sense and sustainability. Lovely.
Thank you.
Are there any other questions? Okay, at this point, we had asked Dr. Pérez-Stable to talk about some specific topics for smaller groups, but there's a small enough group of us here right now. I think if you'd like to stay, any of you, you're welcome to stay. Just to kind of summarize here, from about 1 to 120, we were going to talk about maternal health and health disparities. From 120 to 140, medical and aging issues. And then from 140 until 2, children and health disparities. So you're welcome to come and go as you please. So if you can stay, great. If you can't, that's fine. If you want to come back for one, that's fine too. So at this point then, Dr. Pérez-Stable, would you just give some comments about maternal health issues? I know that you had provided us with some information on a slide about mortality or morbidity. But if you just want to expand on that a little bit.
Well, I didn't prepare any slides or anything for these.
That's fine.
Breakout
That's fine.
talks.
This is completely informal and casual.
Right. Well, I'm a general internist, so for me this was also a newer topic. I am a parent, so I am familiar with many of the sort of the direct issues related to parenting and maternal health. Before COVID-19 hit, this was probably one of the hottest topics, NIH and Congress. And the data I showed you in that one slide from Elizabeth Howell's work was actually what I told a briefing. It was actually not a formal briefing, but it was more of an informal meeting with the the Black Maternal Health Caucus or something. And there were about 15 House members there. Including from both parties, and Dr. Collins and Dr. Gibbons, Dr. Bianchi, the director of National Institute of Child Health Development, and I were there. We each spoke. It was, very more informal, back and forth. When I shared those data, it was one of the African American congresswomen who just said, "Can you say that again?" And so I think that the level of disparity here is really astounding. So maternal mortality, which of course is the worst outcome, is uncommon, almost rare, is about 2 to 3 times more likely among Black women than it is among white women, and among American Indian women. Latino women and Asian women don't have higher mortality, but they have higher morbidity. And that's consistent from the CDC data. It's only measured in 13 states. That's what they're able to get reliable data on. As a consequence of that, we launched a quick initiative, funded 7 grants to do interventions. The interventions were mostly in the clinical space, community clinical space, focused a lot on conscious bias and on preconception morbidity, preconception morbidity. So there are 3 areas here to think about in maternal health, and I'm referring to one is, what does a woman bring to the pregnancy? If a woman brings risk factors, hypertension, and that diabetes doesn't increase the risk of pumping, but extreme obesity. That is something we can work with, we can work on. Lack of access to healthcare, or smoking obviously is important. The intra-hospital experience, so the close to birth and immediate postpartum, is more medical complications. So there are proven treatments for certain things. Hemorrhage is a major thing. This has been more of a child health's domain. NHLBI and NIMHD actually have funded preconception interventions, mostly around nutrition and weight, a little bit on hypertension. And then what happens postpartum? 1/3 of the deaths occur after 6 weeks. And it's not just socioeconomic status and access. We know I think it was Serena Williams, right, who had the pulmonary embolus after giving birth, and she certainly had access to the best medical care, we presume, or no lack of resources. And so the effects on Black women cuts across socioeconomic status in a way that is really staggering and sobering. So this is where the issue of, what can we do about it? The pandemic sort of put a halt on some of the process on this, but it will pick up once we get new funding for fiscal 22. There's a program called Improve at NIH, again, led by Child Health and the Office of Research on Women's Health, and NHLBI and NIMHD are going to be at that table as well. And my way of thinking about it is, it has to include all these components: community engagement. We have to really think about preconception health status. And then we have to worry about postpartum health. So if you provide health insurance or Medicaid, even 50% of births are covered by Medicaid in the US today, out to a year, that will help. I mean, some of the emergency Medicaid that occurs when women give birth and hospitals get reimbursed drops off after 6 weeks. It's not like 6 weeks, you're done. And the other issue is who follows these women. Again, I'm as I mentioned, primary care doc. So I think the family physician or the general internist who specializes in women's health can really be the optimal provider here. Obstetricians and gynecologists tend to be more likely to be surgeons, although some of them could also do it as well if they're committed to the outpatient ambulatory setting. And this has not been a consistent focus. Is assumed, oh, everyone does well, you're going to be fine. And we know that there are also lots of other issues besides mortality or severe morbidity. There's issues around the parenting experience, mental health issues, the postpartum depression that are important. So this continuity, comprehensive perspective on care is important. So do look for initiatives to come out on this in the next this year, once we again get a budget. I think those are so many of the same factors. Women want to be able to communicate with a clinician who will listen and pay attention to what they're thinking. Most of the horror stories we see, and in fact, I think even Serena Williams' story is that the doctor wasn't validating or paying attention to their symptoms. Oh, you'll be fine. Oh, it's abdominal pain. It's just gas. And next thing you know, they have perforated appendix or without violating confidentiality, a very high level NIH person who worked with me on her third baby had a perforated appendix, and she knew what to do and got taken care of. But these things happen, and it's not just everything related to the pregnancy. Other things happen. So I think these are critical issues. And in maternal health, I think in children, from a health care perspective, obviously childhood immunizations is a giant success of the 20th century. It is actually, I would say, for the most part, lack of disparities in the basic immunizations and that we use for children by race, ethnicity, I should say. The vaccine resistance, hesitancy issues were more common in middle class or upper middle class white communities than they were. The newer vaccines, are lagging because access always lags. So things like varicella or even hepatitis B are not as at the same level. And again, the CDC data needs to be made more robust so we can actually understand these differences. So Dr. Newman has her hand up.
So just a question, really, maybe to talk a little more about the maternal health side and who should be following these women. I think maybe your thoughts about the role of doulas and supporting women. So in the state of Alabama, just for some context, the position is that the Medicaid goes away. after 6 weeks, and then they don't really have access to care, right? So, and of course, they're not covering access to doulas either to support pregnant women. And some of our rural women have to drive far away to deliver, so they don't necessarily have good access to care either. And so I just wanted to know what your thoughts were, and NIH's kind of thoughts are around doulas.
I'm a little bit out of my my lane, but I'll say, you know, I'm a generalist, so I always have something to say, right, about most things. There is interest in NIH-1 doulas. In fact, there was a workshop that I think nursing sponsored that we were co-sponsors of. One of our program staff, Priska, I forget her last name right now, is very interested in this. Again, Charlene, if you send me an email, I'll link you up with her. There might be a report from that workshop. You know, I'm empirical, so I think, well, if it works, yes, we should do it. And there's nothing magical about physicians, or for that matter, nurse practitioners, physician assistants. I think women who are generally healthy and have not had complications, you know, have been giving birth for centuries without doctors. So I do think that we can do a lot with doulas or equivalent, and especially when you have to drive 50 miles to see a clinician. I think that's absolutely would endorse that. What research has been done in there? There are some research in it, but I can't cite it off the top of my head. Priska Muhura, I think is her last name, will know more and be able to give you more information of where we are with that. The loss of Medicaid is a policy issue. I mean, we found an investigator who's an OBGYN physician in Oregon. Her name is Maria Rodriguez, and she is on a campaign to change this. And my God, I hope she succeeds. She got an R01 from our institute to do, you know, these large secondary data, combined comparisons of states. It varies by state. You know, it's one of those things where if you live in some states, you do much better than you don't. And it mostly affects, it often disproportionately affects undocumented women who are Latina, who are mostly undocumented. But as you said, if you're uninsured and you have no Medicaid, it drops off after 6 weeks. Like, oh, you're fine now after 6 weeks, when the clearly evidence is that at least a year needs to be covered. And I think they're working on this change. And I like to think that we have an opportunity now to make a difference in these issues. But again, CMS would be the place that would make the policy change. We're talking to them a lot more. And in fact, I'm meeting with one of the leaders there today, late this afternoon. And so these are important issues. It's usually Medicare, because that's the big group that has the most data. Medicaid doesn't often come to these, although it is the same agency. So now, what kind of physician should follow is just whoever is willing and able and skilled, and it can be a nurse practitioner. I do think the team's approach would be great. So let's say if the doula is seeing someone and the doula sees a problem that is not understood at 50 miles away, has the ability to say, let me call the doctor, the physician, 50 miles away, to say, I'm not sure what to do about this. What do you think? And then the other clinician can make an assessment. Mm-hmm. You got to bring it in, because I think that's where we're often missing. Then it's up to the patient to say, find out who can help you when you're sick, and that's really it's really not at all optimal.
Mm-hmm.
There was a question that came into the chat from somebody who had to leave. So I'm just going to read it for you and hoping it makes sense, because I probably won't be able to help you at all. So here it goes. Patient-clinician communication and patient-centered care have been put forth as approaches, often occurring in tandem, to reducing severe maternal morbidity and structural racism in perinatal care. Mm-hmm. I know you stated that gaining knowledge of AI is important for all of us as we move forward, but communication and patient-centered care are often limited by technological advances. The question then is, what advice do you have to explore these topics, keeping in mind that things like AI and other technological advances are prioritized by NIH institutions?
I'm not sure I quite get the gist of the question. So,
okay, so what advice do you have to explore these topics? So patient communication and AI.
I was going to answer anyway, but I wish the person was here. But anyway, you know, the clinicians, you know, it's sort of a lot of it relates to the reimbursement mechanism, all this, but the people come to see a clinician to get, you know, trusted advice and of course manage their problems. You know, they want to feel better. They also want to feel like, okay, what do I worry about? And then we have all this prevention stuff that we want to do. And of course, if they have a problem, we want to control it. And so clinicians, especially doctors, physicians, are focused on making sure they get that stuff done. They check those boxes. You know, their blood pressure medicines are prescribed, that their blood tests are, their serum creatinine is done, all these things. And the importance of just connecting with a person on a sort of individual level, sort of, who are you? You know, what do you like? You know, I think that's the philosophy I would promote most importantly in communication, with the idea that I'm not seeing you just once or twice because you have a problem that I'm the one who can fix it, a surgeon or a specialty consultation. That's a different mindset. My mindset is we're going to be partners in your health for years, possibly, I hope, if you agree and if I'm still here. And that's the way I think that would be the optimal way of caring for people in any kind of condition. And so we haven't really taken communication until even now, I think, in most places, as a rigorous skill that is learnable. People kind of take it for granted. You know, oh yeah, I can just be nice or charming, and some people don't care. They're just rude all the time. And you know, valuing that as a clinician is really important. We shouldn't have clinicians who are taking care of patients who don't know how to communicate. Now, all of us are going to have interactions that are not going to go well, because if you see 1,000 people, at least just by randomness, some people are not going to like you. We as professionals have to say, well, we have to check that this person really doesn't pushes my buttons, but I'm a professional. I have to connect with them. And I think these are skills that are important that in medical school have not been emphasized sufficiently. I can say very limited, almost none. In my time, many years ago, I think we've done better over the last 4 decades, gradually, and certainly in some specialties, these have been prioritized. Obviously, in psychiatry, it's used to be the primary one, then all the drugs came out, but clearly it's still an important one to emphasize. So that's technology made it more complicated. Now, all of a sudden, doctors were looking at the screen. Since I can't type, I never had that problem because I had to look at the keyboard to type, right? So I always kept looking at the patient and did all the work later. But most of my younger colleagues were, like this, and I think it was efficient and better care. You had all the information, but we lost that connection a little bit. It got diminished, and people have attended to this, and so my own idea of what's a better structure to help this is to not have fee-for-service. If I had the magic wand, if I was in charge, to create sort of accountable care organizations that have a budget. There's some flexibility, and the budget allows you then to have a clinician to be in charge of a panel, and you take care of your panel, make sure that they're being taken care of, and not have, okay, you have to have 12 visits in half a day. Which is what we did at UCSF, was because we were being reimbursed on a fee-for-service basis, even though we had other agreements, and of course everybody's a faculty and they're all got a salary. We still had to balance our budget, so to speak. And I think that approach will and then allows you to say, well, these patients really need more resources. So we need a sophisticated coordinator to help us manage people who are all, they're in the emergency room multiple times a week during the day. Something's failing them and we're failing them as a system. And I think when I left UCSF, the medical center was just understanding the importance of that and allocating pilot resources for doing these kinds of studies. Well, identify your sickest patients and let's see what happens when we get a coordinator in. And the coordinators were either like a nurse practitioner level, or we had a social worker with an RN. I mean, people who were more than peers and really, really help manage those either psychiatrically ill patients who also had a medical issue, or very, very sick medical patients who sometimes were, nearing the end of life, but not quite there yet, not yet in the palliative care hospice type of model. Are not ready for that yet. So as best I can do. Technology is wonderful, but we need to leverage it to our advantage and not let it distract us from the important things in clinical care. And I think the initial wave of EHRs did that. We now need to adjust. It's a powerful, powerful tool. The discovery science part is really for research. And that's more for someone with asking questions of big data sets. And I think, that time is here. So.
Okay, sounds good. Now, yes, we'll change hats a little bit and go on to the medical and aging issues and health disparities. If you want to just give some comments, and then we'll ask questions.
Well, I'll comment that in aging, we had a research center for minority aging research at UCSF, and it's still there since 1997. We had it. Leo Carliner is now the principal investigator. I think there's one at the University of Alabama again, in case you're interested, at Birmingham. Lots of interesting things. So demographically, you look at Latinos, for example, the proportion of older 65 is smaller. That's going to change because we're all aging, right? So this large group of younger Latinos are all aging. African Americans and whites proportionally are similar, and the issues are different. African Americans and whites, if you get to 65, at least pre-COVID, there was no mortality differences anymore. So the life expectancy gap is been eliminated since about 2008 in the Black-white adults over 65. Probably COVID has influenced that, so we'll take that with a grain of salt. But African Americans reach 65 with more comorbidity, more chronic disease, more arthritis. They're more likely to go to a chronic care facility, nursing home, with advanced cognitive impairment. About 80-90% of people in chronic care facilities have some level of significant cognitive impairment. And I think this is enough information on it that I think we can be confident in saying that. Much less is known about the other minority groups. Latinos, we do know, are more likely to stay at a nursing home, stay at home with moderate impairment and chronic comorbidity. We don't know why. We don't know how that's sustained. You talked about the Black Belt and rural Deep South. Similar issues are experienced in the Southwest with rural Mexican Americans, and there are data on that from the epidemiologic study that Coco Marquides has done for years out of University of Texas Galveston. So it is a study of the Southwest older Mexican Americans, mostly Mexican Americans. And in San Francisco, we worked some with the Chinese community and Korean community, and there's all dynamic, interesting things there. I mean, they come from a culture where the children were responsible for taking care of the older adults. Then they come to the United States and they see the struggles for people to do better economically, and they kind of don't want to hold back their children. So they are now socially, many of them are socially isolated in communities, and the children, adult children, have moved out to the suburbs because they're doing better financially, but they don't take the parents with them. Parents are staying in their small communities in San Francisco or Daly City, and so it's a whole other. So these are all fascinating issues that, again, the intersection of social, behavioral, and medical issues.
I have a quick question. I'm sorry.
Yes.
I don't mean to
Go ahead.
interrupt you.
Please, go
I
ahead. Go ahead.
apologize.
No, I'm
I
just
was
talking.
One of the questions I guess I had, one thing I put a note in the chat about the Deep South RICMAR being a consortium. But one of the things that some of us have encountered, and I'm curious what your thoughts would be on it regionally in terms of health disparities.
Mhm.
We've had grant feedback from different study sections about how any program or measure or intervention developed and coming out of Alabama, certain study sections have said, gosh, that's just not applicable. It just doesn't really, it won't have anything to say to the nation at large. And I'm curious what you think about that, or how we might address it in our applications.
You mean that a research product coming out of one group isn't taken seriously by a study section or applicable?
No, that's the specific feedback was that Alabama is different, right? You spoke to this a bit in your presentation earlier today, that the Southeast is different, and the conditions within the Southeast are different, and therefore it was one of the, so I mean, the proposals, I have one specific one in mind, got 20 something percentile. So it wasn't poorly received. It was, what do you have to say to us? And I'm just curious for all of us, if you think that's just a quirky study section, or if that's something that you have a strategy to address.
Yeah, we can always blame study sections for everything, right? Because I think they always get, and review is really fraught with issues, although they do a yeoman's work. I apologize. I don't know the details of all the stuff. Even though I led the RICMAR in San Francisco, it's been a while. That it's great that you have a coalition, and we do fund Tuskegee and Morehouse with research centers and minority institutions, and so this is great to see that this coalition has worked. And I think that's not true at all, because then that would be true for everything. Then all the studies done in Boston would mean nothing, right? I would see that comment too sometimes about Northern California. Oh, it's different, and how can that be replicated? I think that's going to be the case in any study that we do. We can't always generalize to everybody, but there's value if you've asked an important question, either made important observations in an observational study of associations or in the causal pathway, or done an intervention that had an effect. I have no reason to dismiss any of that, no matter who did it. And I would say that, one of the challenges that comes up time and time again, as I'm sure you're very familiar with, Rebecca, is, if you look at the geography, and I didn't show that slide because of time, or didn't put it in the presentation, the map of the United States and life expectancy, chronic disease, you see this consistent pattern of a part of the Southeast that has the worst outcomes nationally, whether it's life expectancy, diabetes, or heart disease, or you name it, almost everything is worse. And I think that there's a reason for that relates to a lot of complicated factors, including social, behavioral, and structural ones that people haven't paid as much attention to. So, and I think most scientists at NIH, most of the NIH leadership is very familiar and aware of that, and not at all dismissive. I would say there's added value to doing work in Mississippi and Alabama and Arkansas and Louisiana and Georgia. So I wouldn't at all dismiss it. In fact, we have significant bias in that direction or investments in that direction. And I would think that, the Jackson Heart Study is in Jackson, Mississippi for a reason. And you could argue, well, it's a one-site study. It's not as good as, this other study that has 5 sites. Well, maybe that's a limitation, but there's also an opportunity to do more in depth. And Framingham was a one-site study, and yet everybody refers to it in a mostly a working class Boston suburb or Massachusetts city of working class whites until they added other waves of African Americans primarily. So I think that's it's irrelevant. Good science is good science, and I wouldn't let that get to you. Again, kudos to you, to the group that is doing the coalition. Maybe you're also part of their multiple chronic disease research centers that we funded. Selwyn is the PI. They didn't engage you guys? Okay. Well,
No,
they
didn't engage us in that one.
Well, they'll have other opportunities to do that because they should. It is, the Multiple Chronic Disease Research Center, by the way, was, I think, written with the intent to be, you have to address at least 2 diseases, chronic diseases. You had to be regional, at least, and you had to be more than one institution. There would be a lead institution, but they had to have more than one involved. And these are, $3 million centers per year, so they're not small. And they needed to have. Now, we ended up funding, I think it was 10 or 11. Many focused on the metabolic diseases, diabetes, obesity-related issues, cardiovascular disease. A couple used chronic liver disease. A couple used cancer. Nobody focused on osteoarthritis, even though we put it into the announcement. Nobody wanted to do osteoarthritis, which is disappointing. But we will. This is congressionally mandated, added to our base, so we'll continue. And if NIMHD gets a budget increase, we'll see what happens with all of our programs. So
a question related to maybe, I don't know, just a question or a comment. I'm not sure what it's going to end up being. So you mentioned earlier, and this is something that quite a few of us have been thinking and talking about, is this relationship between early childhood stress and then chronic psychosocial stress on aging, right? And so what happens when you're, like, say, over midlife to older, right? And this idea that the chronic stress and all of the things that happen sort of triggers a lot of these metabolic diseases, and in some ways they may have some common-ish kind of
yeah.
And how that may contribute to some of the racial health disparities. So is that something that your group is kind of really focused on, is looking at that long-term, longitudinal kind of study of the impact of these stressors in younger life?
Yeah, no, I think from a scientific perspective, I would say that's widely accepted now. The early childhood events are really impactful, and not just on development of children or behavior and mental health of children, but on chronic disease. I think the link to chronic disease is more tenuous. And there is still not a lot of empirical evidence to support it, but people accept it. How do you get a cohort of 50 years? That's the challenge. There's actually when I looked into this a couple of years ago, there's some European study of the children of I guess family or men who families where the man had died in World War I or something, and there was some follow-up on that. The National Institute on Aging was interested in, it has been very interested in this, and trying to find other data that we can go back and find linkages to from like the 1960s and stuff. Most of them are in whites, So I don't think that we will understand the race dynamic or even the socioeconomic dynamic, because they're often not necessarily collected, although you can get some sense. So yeah, this is an area that we are very interested in, not just in IMHD, but I think others. And that it would, I put it in the context of exposure to racism, which is then, okay, how did you measure that back in 1960? I mean, it'd be hard.
Right.
But
Right.
I think you have to deal with these, where you lived, what the time was, and
So one of the things that I've had maybe just a couple of conversations about, and probably with Pam, who I think may have left, is we're being in the Deep South. There are some communities that may experience more racial terror than others, right? And so, and looking at sort of the health outcomes in those communities versus other communities, right, that may have had less racial terror. I think they all probably had some, but but sort of looking at some of those differences across communities. So, for example, I'm right now sort of working with a number of communities within the Black Belt, and noticing differences in them, even though some of them may be like, all of them I think are predominantly African American, but the relative kind of I guess sense of empowerment and health are somewhat different across them. And it's just made me think like, okay, is there something that happened that kind of triggered, like what's going on with, with to explain some of these differences, right? So I think there may be some interesting ways of getting at that, looking at communities as opposed to individuals.
Right. No, I think you're onto some important point. I don't use that slide as much anymore, but there are data. There was a study published a number of years ago in JAMA that looked at the association of income using income tax returns and outcomes mortality, and showed dramatic differences in different communities. The study was done by economists, so their interpretation was that the differences were related to behavior. But I don't think you can explain a 2 to 3 year life expectancy difference on that alone. And in fact, for example, Birmingham, again, just because it sticks in my head, compared to Detroit, did much better in life expectancy. In San Francisco, Manhattan, where you can explain perhaps because of the socioeconomic status, but not, there is something to be said about what a community can do to do better with its most under, and that's coming back to me. The analysis was what the lowest 20th percentile in incomes life expectancy was. And this is massive study with millions and millions of individuals. The way they did it, it was a guy named Chetty, Raj Chetty. He's now at Harvard. He was at Stanford at the time, and I can't believe that this was related to anything individual, but it had to be more community focused and how different communities do better in taking care of their most vulnerable. So it wasn't just a global life expectancy; it was the life expectancy of the most vulnerable. And so I think that that is a very valuable, very valid point. Now, in the aging issues, are you doing work with it kind of in the life care or palliative care or any of that stuff? Yeah.
There are folks on this call who do that. Yes.
I'm sorry.
Yes, there are folks here present who are focused in that. Yes.
Because I think that's been from a clinical lens, often understudied, particularly in the populations with disparities and minority communities. There are really very few investigators who have really focused on this. And again, it's the value of the non-biological side of research, because it's about communication and social support and providing options and preferences, and as opposed to, am I doing the right test to get the right treatment? And as one of my colleagues said, one of the things you do when you see an older adult older for me now is 80, but the old, because that really is, the shift in time has moved forward. People get to 65 much healthier than they used to, is to take them off medicines. You get an 80-year-old on 10 medicines. So why are they taking 10 medicines? Do you really need to still take a cholesterol medicine? I mean, sometimes yes, the answer is yes, but and I think that we lose perspective on that. So
I'm curious what you would say, sir, about the relative emphasis of the different institutes in the palliative and end-of-life care area. I know NINR really was sort of spearheading NIH's palliative care research. I don't know if that's changed. It heartens me and others here. Dr. Ellen CK is one for sure who does palliative care research. To hear that might be an area of interest in terms of disparities. So
right.
Are there other institutes interested is the question.
Well, obviously National Institute on Aging. And I think
National Institute of Alzheimer's
that's their good fortune
focus.
and their curse. Richard Hodis is, their budget has increased significantly, but it's all Alzheimer's budget. I think we definitely would be interested in studies of this type. We have funded some R1s. I do remember seeing them come through our funding discussions. Because it is such an understudied area, I would welcome those kind of proposals. Shannon Zenk, the director of NINR, who started a little over a year ago, is fantastic. I think she will sustain the interest in the life care as she shifts to more emphasis on population health. And actually, we're partnering a lot on initiatives in the Common Fund and other things. And I think that's going to also contribute. I don't know about others. Maybe NCI, because of their survivorship program, will also have a component of interest in this. I don't think any of the other institutes have expressed. Complementary medicine, but their tiny center might have also a program in this. So.
Okay, I think we should move on then to the last topic, which is children and health disparities. So just some general comments, and then we'll pipe in.
All right, you're challenging me, right? Maternal. I thought it was maternal and child, but it was only maternal. So my knowledge about children is informed in large part by having raised two, but also really having worked with pediatricians. Children do well, and so if we screw it up, then they don't. That's one idea. We already talked about the importance of early childhood care, early childhood support, the social support, the nutrition. There are a lot of interesting areas. Obviously, the health from the healthcare system, getting kids immunized is really important. And I think that's been one of the remarkable advances of the 20th century. In that, when I asked my residents in the 1990s, how many of you have seen a case of measles? No one had. I had measles as a kid. So, and yet it is a disease where we've essentially eradicated from US-born children, and that has not been lost. The varicella vaccine came out. We received plummeting of not only varicella in children, but also the ability for people then to go to work because they didn't have to stay home when their child got varicella has been remarkable. So sometimes you have these unexpected benefits. The pneumococcal vaccine in children in early childhood led to a decrease in pneumococcal sepsis in adults because there was less bacteria circulating in households. That led. So we have lots of evidence of how these have been. Chronic disease in children is primarily asthma, some gastrointestinal diseases, and then there are all the uncommon diseases of which I'm much less conversant in. Cystic fibrosis, which is, I was called on this by an advocate, it's not exclusively a white disease, and that's important to say. There are genetic markers that often aren't screened for that are more likely to affect non-whites with cystic fibrosis, even though they make up 3, 4, 5% of the cases nationally. And it's important disease to recognize. Now we have an effective treatment. So even sickle cell disease has been, people have made comparisons. Sickle cell disease didn't get nearly as much funding as cystic fibrosis. That's been changing. And there isn't actually a vision of curing sickle cell disease. And Dr. Collins actually was one of the ones who was thinking about this through the gene editing technology, not to replace the missing allele or the missing amino acid. That's too hard. But to actually modify the gene to increase the manufacture of fetal hemoglobin, so that if you turn on fetal hemoglobin and get it up to 30, 40% of hemoglobin, then the people with sickle cell disease will have much, much fewer symptoms, not zero symptoms, but much, much fewer symptoms. We do see this already in some variants of sickle cell. SC diseases can be like that more commonly. So I think that those are things I'm familiar with. Asthma has been sort of the prototype. It's intermittent, it can be severe, it can be disruptive to the child and to the family, lose school, lose work, etc. Eminently treatable, but then you have to, and what's the best way to do it? There's an environmental component that's really important, and people have what do we know? I mean, for a while there was thought that insect, infestation, cockroaches would contribute to this. There's some evidence to that related to the antigens. Pets can also contribute with the mites that live on the pets that then trigger the immune reaction. Mold in poorly ventilated homes, which are unfortunately more common than we would like to think, also contribute to this. So these are, again, environmental approaches to a medical disease that has got pharmacological treatment. There are some very good long-term studies on asthma in minority children, both African American and Latino children. Curiously, the groups with the two highest rates of asthma are Puerto Ricans and African Americans, and then Mexican Americans, who are also Latinos, have one of the lowest rates of asthma of all. And understanding what that's about, I think there's been the life work of a group of investigators. One of them is at UCLA. Well, he's the lead of the group, Esteban Bouchard, who's been focused on this for now 20 years. Pursuing sort of biological differences in terms of genetics, but understanding also the social, environmental, and family differences that exist in a large cohort study. The ECHO study exists. This is the cohort of cohorts. It was retrospective to begin with. And now they're going to do new collection of, I think, 20,000 parental mother-child pairs. Matt Gilman is the director of that. That's out of the office of the director. It's data that should be available for analysis to anyone. You don't have to be part of the in-group to get access to it, although I'm not sure they've worked out all the details. That was the product of the Children's Health Study, which had failed, and that all got done before I got to NIH, and Matt joined NIH just shortly after I did. So they recruited him to run this. I think it has been very successful. I mentioned the ABCD cohort, which is very much has data. They've already recruited the 12,000 adolescents now. These are adolescents. So in adolescence, it's all about, you don't want to say sex, drugs, and rock and roll, but it is. A lot of issues around substance use. Mental health is the other big one. And of course, it's brain development period of life. And so people are, that this is what many NIH scientists were interested in, how does the brain evolve? It is modifiable. If you look at the brain imaging data that has come out of the Brain Initiative, it's just astounding what a 3-year-old's brain looks like compared to a 30-year-old in terms of what parts are activated. And it's in adolescence that those parts get turned off, the parts that get turned off, although you can actually recapture them later. So this whole idea that, oh, you're done, you're an adult, you're done, you can't change things is not true. The brain is, there's a lot of plasticity in the brain. And this midlife plasticity has also been an area. NIA has been very interested in this. They're not just about people over 65. They really want to focus on what happens in people, 40, 45 to 65, because that's a time when we see excess. Really, the biggest gap in morbidity and mortality for minorities is in that age group, actually, as
What
opposed
about
to over 65.
Sorry, what
Yeah.
about developmental disorders and health disparities? Or, I think of autism. I have a colleague I work with. This is not my area, but she's very much focused into autism and often talks about the fact that children aren't identified in rural communities to the same extent that they're identified in urban communities. So is this institute interested in funding any of those types of studies?
It depends. That's my cautious answer as director. I think I would say probably less of a priority for us. And IMH is really focused on autism, but if you have a good, a good solid proposal that is, we know this is not disproportionately affecting this group, but it does still happen. How do we study this? And gets reviewed and assigned to us in a high score, we will fund it. My review of autism was that it is more common in whites and less common in minorities. Attention deficit disorder, which is much more common overall, happens more frequently in minority children, and that carries these consequences in adults. I think it's safe to say that NIMH is the institute that is focused on autism mostly. So I would defer to that group for the expertise on it. Yeah.
And I'm not sure if I'm saying things out of turn, but I think she would say that NIMH is interested in biological issues associated with autism as opposed to behavioral issues. So
yeah, I think that was true, very much true in the prior director. I think Josh Gordon, who's the director, has really, I wouldn't say completely shifted away from that, but has sort of modified that in his role as director. He came in a year after me. I worked very closely with him on a couple of initiatives, and I can guarantee you that he definitely is tuned into the behavioral and social issues in health. And I don't think that would be the case today. Now, it is a competitive field out there to get grants. So I can, we did fund, for example, and just to give you the example of NIMHD, and this was a persistent investigator, a K award that was focused on multiple sclerosis in African Americans. I think it came out of an institution in the South, although I can't remember which one. And first time we didn't fund it, and she came back, or maybe we eventually funded it the first time because of the end of the year, funding. Maybe she revised it and came back and got a better score. And I kept saying to program, well, why should we fund a disease that really is very uncommon in this population? But they made the case, well, it's uncommon, but they do worse, and we should study it. And we eventually we did fund it. So I wouldn't give up on that. So
actually, since you mentioned that K award, I might have misread that slide where you showed the increase in K awards, but it kind of looked like everybody who applied for one of these K awards received it.
No, it's not the case. I think with K awards, unlike R1s, I've been using more of a pay line approach. So if they get peer reviewed and they scored under a certain score, I've been using 30. We really try to fund it, and I go out of my way. It's a small investment for the future. That's what I tell staff. So I think of it that way, and I know how valuable they are to investigators because I had so many faculty that had them when I was at UCSF. We might be able to do more if we get the increase. But it's not, they have to get scored and they have to get a score.
Yes, right.
But we just didn't have any applications initially. So we had very few the first year we were open to it. Now we're getting a lot more as people have discovered that they can send us K awards.
Right.
And I think that's great. I think, and eventually it'll be a steady state. How much of our funding is going to go to Ks will be based on how much money we have. It's not rocket science, as they say, right?
Right. Okay. I
Jessica,
think
you're
that
up.
might be it.
I
Sorry,
have one quick
Shreya.
question.
Go ahead, Jessica.
Oh, sorry. I had to switch to my phone because my laptop was going to die here. I'm just kind of asking a question really to gauge interest. My field is public health and athletic training, really looking at sport as a proxy to exercise to reduce chronic disease development. Primarily working in Black belt communities with football teams, actually. So I'm just really trying to gauge maybe the Institute's investment or interest in youth and adolescents, sport and exercise, really looking at this kind of globally, just because of the reduced access to physical education in schools, the structural racism within these communities, but then also the social element and support that kids playing sport really get. So just kind of gauging some interest there.
Just protect their brain. I think physical activity topics have been supported. I don't know what from the beginning in our institute. So yeah, absolutely. And I didn't mention this, but I think it's so important part of healthy living. A lot of times, both clinically with patients and people say, well, about their nutrition or this or nutrition or that, and there's a ton of stuff on nutrition, but incorporating some form of physical activity in one's routine is an essential part of healthy living, I think. And we're not built to be sedentary, although eventually that may happen. And so because we don't do that anymore for livelihood, many of us don't anyway, we have to build it in. And I think sports is a great way to do it. And hopefully establish habits that will be sustainable in the adolescent years and in the young adulthood years. I think that's a critical transition there. That we talk about children, but I think that the other area I think is understudied, I would value, is that transition from what we call children, 18 or younger, to young adults. Things have changed. I think now we've shifted a lot of things to young adulthood. You see this in behaviors, exposures, and that 18 to 24 age range is a critical group that I don't think there's different groups of people studying them, and even different measures. And somehow we have to find more focus on that transitional period, and not just, oh, I do adolescent medicine. Oh no, I do adults, and then the young adults get lost because generally they're healthy. But we do support physical activity interventions and engagement in communities around inactivity. You might get some pushback on football because of the risk of trauma. But in general, I think that's a good thing. So,
Thank you.
So any final thoughts, since this is your your last meeting with us, or advice or something?
Well, general advice about being persistent in what you're doing. Research is a delayed gratification field. You haven't already discovered that. Teaching and service and care, clinical care, you get short-term feedback right away from patients or learners or community members. A researcher are going to be slaving away for 5 years and nobody notices what they're doing. But eventually people will, especially if you're persistent and get your work out. I used to tell new fellows or researchers, the hardest part about research is writing. And they'd look at me like I was talking to, I don't mind. Now, a lot of them were physicians who forget how to write when they go to medical school. So hopefully PhDs haven't done that. So, but I think being diligent about getting your products out, especially in this day and age when anyone can find what you've produced in PubMed or Google Scholar, or whatever, that I think is important. It's cumulative and slow. And this great discovery is everyone's going to think, oh, well, look, a wonderful study. It doesn't happen that often. If it does, enjoy it and be good about it. But don't expect that that's really going to happen all the time or anytime. So.
Wise words. Well, thank you very much.
Thank
Dr.
you for the
President.
opportunity. And I will remember you're the University of Alabama, no modifier. And of course, I'm familiar with the football team. I guess condolences for this earlier this week, but as one of our
Keeps us humble.
Yeah, one of our NIH leaders, Alfred Johnson, who's the director of management administration, he's a PhD scientist, is a rabid University of Alabama football fan. So he was getting some jokes at the meeting on Tuesday. So, but all in good humor.
Yeah. Well, thank you so much for spending all this time with us.
And follow up with the people I said to send me emails. Thanks. Bye-bye.
Thank you.
Thank you.